Again, thank you guys for having me. I am a pediatric orthopedic surgeon. I did not do an adult spine fellowship. I did a ped spine fellowship or a pediatric ortho fellowship and did a lot of spine. So my practice is a little bit unique. Since I am a pediatric orthopedist, I still take call and fix fractures, but my elective practice is all spine. So that's why I was invited today. I started a robotics program at Dell Children's, which is our children's hospital in Austin, when I came out of fellowship. And it really was because I had just some really great training and fellowship that I was able to do that. So these are my disclosures. Objectives for today. We'll talk a little bit about what I think the indications are for pediatric surgery, and we'll talk a little bit about what other people think they are. And we'll just go through my OR workflow because it is a little bit different because the anatomy is a little different. Some pearls and pitfalls, and then just a really quick case at the end. So in the peds ortho world, at least, there is a really big hesitation to adopt robotics. Pretty much everybody is very skeptical. There are a few of us that have really adopted it and gave it a big hug and love to use it. But there's a lot of people that were having trouble convincing of the benefits of it. Their complaints are that it's inefficient, that it is a big capital purchase for your hospital. The radiation exposure is a huge concern. Also, as we heard from Kareem, a lot of people just don't think they need it. They've put in a ton of pedicle screws in their lifetime, and they don't think that it's worth it. And then probably the biggest one is, the safety and accuracy concerns that you've heard about throughout this entire morning. And especially when we're doing this in kids, most of our scoliosis cases we have a pretty dysplastic pedicles, and there's really little room for error when we're placing these pedicle screws. There's a lot of safety data in the adult world, but in the peds world, our safety data has only started to come out over the past couple years. So we have, a couple high volume centers, not very many, but a few, that have put out their safety data. And this one is the most recent. They retrospectively looked at, over about 5,000 screws placed in 334 consecutive patients at 2 high volume centers. So their complications, they did have 1 durotomy. They had 6 monitoring alerts, which were not associated with putting in the screws, and they were associated with correction. And then 62 breaches, which is only about 1.2%. And that actually, when you think about your freehand breaches and your rate of that, that's smaller than freehand. So they concluded that's an acceptable safety profile to use in the pediatric population. Same thing here. This was from my mentor, Boston Children's, Dan Hedquist. He looked at his experience over 3 years, 2019 to 2021. They had 1,467 screws attempted. They were able to successfully execute or successfully put this screw in the right position in 1,461 of those screws. So that's 99.6% success rate. And you guys that have done robotics starting in 2019 or before know that with the Mazor at that time, you didn't have the high-speed drill. So actually, all the failures of the screw placed were in type D pedicles placed lateral before they had the high-speed drill. So there actually was zero misplaced screws after the initiation of that high-speed drill. So what makes pediatric surgery different than what you all do? Kids are not just little adults. We're working with a lot of smaller anatomy. A lot of the cases I do are on teenagers, but sometimes I'm doing cases on 3 and 4-year-olds for congenital cases, and that's very, very, very small anatomy. Most of my cases have pretty dysplastic pedicles. This is an example from one of my mentor's cases, but especially on neurofibromatosis patients, there's no pedicles. And if we're going to try to get screws in, it's really difficult to do that freehand or even navigated. To place those extrapedicular screws, robotics is really helpful. And then we're also dealing with rotational deformities. Most of our cases are scoliosis cases. Some of them are pretty significantly have a big axial deformity, and that sometimes can be challenging. For the robot, and there are some nuances with that, and you definitely, there's a big learning curve with that. So indications for use in ped spine, for me, if they need surgery, I can use a robot for it. So I really I love it for my AIS cases. For neuromuscular, it's also awesome. We run into if you're doing a T2 to pelvis, it can add a little bit of time, but that's where, as we talked a little bit before, you can robot the parts that you want to robot and then freehand a lot of it to save you some time. Syndromic cases can be very helpful like I said, for like the neurofibromatosis cases. Congenital cases, it's awesome for, especially if you have a platform that can easily go between robotics and navigation, because you can place your screws robotically and then navigate your like hemi-resection, and that is really it's a very powerful tool for that. Also, probably one of the biggest when people have adopted this early, it's really high-grade spondy was like honestly the ideal case for this, because as you guys have said before, it's really hard to get those freehand screws in for L5 and L4 when you have such a high-grade slip, and using it turns a really hard case into a really easy case, and so in the peds world, people are starting to recognize that. And then, as we heard from Dr. Skaggs, PARS repair is now kind of the newer thing that we're talking about, and some of us are trying. So my workflow, I do use the Mazor X with Stealth. I will say the workflow in peds, as with adult, is really variable. So if you ask me how I do my surgeries, it is different than Mark Erickson in Colorado, Dan Hedequist in Boston. And we all have kind of created our own little workflow and how we like to do it. The way I like to do it is I do my exposure. It does tend to be a little bit wider than a normal exposure if I'm just freehanding using nav. This is a point of contention when you do your facetectomies, because these spines are pretty mobile. When you guys are doing adult deformity cases, that spine's a little bit stiffer than ours, and so when you're using robotics, you're a little bit worried that any kind of little pressure there that you put on it, if you destabilize the spine at all, it causes you to have more loss of accuracy. I've found that I can safely do facetectomies before. That's how I was trained, but some people will argue that you should do your facetectomies after. I then mount the robot to the patient. As we've talked about before, there's a couple options. For the thoracic and upper lumbar, I do the spinous process clamp. I do use a PSIS pin for the lumbosacral spine. That's just a video that's one of the things that you need to make sure when you use the PSIS pin is that you keep it out of the way of your S2 AI screws. And then you attach your navigation array. So we've already kind of talked about this a lot today, but the way that I was trained originally to use the robot was we actually put the robot mounted array, and that's how I learned how to use it. After talking with other ped surgeons that have done this, Mark Erickson kind of showed me that when you put the array on the patient, it does add another accuracy check and a little, definitely makes it safer. So I've started to do that. So when you're doing your registration with the Mazor, you have two options. You can do your intra-op 3D imaging with scan and plan with your O-arm or your 3D C-arm. It is easier, right? You just bring in the O-arm, you get your scan, and you have your images. However, then you have to plan your screws intra-op. So, when you're doing if I get a whole one registration of the O-arm on a smaller kid, I can get sometimes 8 or 9 levels, and that is a lot of screws to plan intra-op. And if you don't have a rep that is really facile at planning your screws, it can add 20, 30 minutes sometimes. So I really, I try actually to not do this protocol if I can get away with it. We do use a low-dose radiation protocol when we do the PEDS cases. Our other option is the pre-op CT to fluoro workflow, which I actually, there's not a lot of PEDS people doing this workflow because it is more challenging. So when you're doing it with a big curve, it's really hard to get the right shots. And there's a big learning curve of, the AP is really easy, but that oblique shot to make sure that you get the end plates on FOSS, it is really, really, really challenging when you have a big scoliosis curve. So I tend to use currently the CT to fluoro workflow for curves that are about 60, 65 degrees and under. If it's anything over 65 degrees, it gets to be a little bit more challenging. And then I'll just do the O-arm workflow from the beginning. There has been a couple times, maybe 2 times, that I've tried to do the CT to fluoro workflow, and I tried to push it, and I just couldn't get it to register. We've took a couple different C-arm shots, and I just could not get it. So then we had to bail and do the O-arm spin, which in peds, I hate doing it, because then I've rated them twice, because I've already got a pre-op CT, and then we're doing another O-arm spin. So I try not to do that. So I try to be really judicious and think about which workflow I want to use. The benefit of that, again, screws are pre-planned. So now we're ready to robot. This has been said time and time again, but I don't think we can say it enough. The accuracy safety check is really, really, really important when we're instrumenting a thoracic pedicle that is very small. So our safety check is using the chicken foot, just putting it on the spinous process, since we're doing all this open at this point. Then I use the high-speed Midas. And this is also where we vary in the peds world of what we do. High-speed Midas, me and Dr. Hedequist do tap, and then we don't place the screw through the robot. So the thought process behind that is when you are drilling, drill tap, and then if you're still putting your screw in, we're getting such good bites on these screws that it torques that vertebral body and then rotates it, and then we're afraid that we're going to lose our registration. So the current way that we do it is we drill, tap, move on to the next level, and then put our screws in freehand after I do my osteotomies. I can't always get my level safely, and I know we talked about this a little bit earlier. Sometimes I feel like I maybe push it a little too far, and especially at the top levels, it's not exactly accurate. So this is where it is important I think it's important to, still have your freehand and your nav screws, that you can get screws at those levels if you still want to without doing another registration, because that does add time to your case. And sometimes then I'll just also use hooks at the top if I want to. So we've done the robot. I actually move it out of the way at this point. I take it off the bed. Then we do our posterior column osteotomies in the levels we want to, without the screws in the way. And then we put our screws in freehand. For my deformity corrections, I use all uni screws if possible. Sometimes polys at the top. Okay, so now going through some pitfalls and pearls that we have come up with run into along the way. So this is one of the things that we maybe touched on a little bit today, but I don't think we've really driven it home yet. Skiving of the drill in peds, and I think it just with this specific anatomy and the rotation of the spine, we run into this a lot, actually. And so before the high-speed drill was introduced, it was before I learned robotics, but from my mentor, he was not a nav guy. He went from freehand to robotics, and he actually hated the robot in the beginning because he was running into so many issues with skiving of that slower drill. And kind of it changed the game for him when he was able to use that high speed drill. So what I mean by skive is, so when you put that sleeve down, especially I think in the adult world, it doesn't really hit the TP in the same way that it hits in the peds population, especially when it's rotated and you get like some deformity of that transverse process because of the rib. And so it's really easy sometimes when you put that down, it really does come into contact with it almost parallel, and it will change your trajectory if you put that sleeve down, to like put too much force on that sleeve. So either one, you have to really prep your bone in that area first. Remember, we're doing this all open still. So you can just prep your bone and make it a flatter surface, or just pull your cannula back and then make sure that you are not having it interfere with any of the bone before you start to drill. He actually wrote about this because it was such a big thing and game-changing for him when that high-speed drill came out. I don't know if this is going to play. Let's see. this is kind of shows a good example. So you can see, like, if you push that cannula down further, and I think this is where some people actually get into trouble sometimes with MIS if they don't know what they're doing. They run into some other bony prominence that they're not really expecting and push that cannula down, and it will change your trajectory. So what you have to do, again, if I make this play, you have to pull your cannula back up a little bit, and make sure, we talked a little bit about this earlier, but we still have our haptics when we're doing robotics. People talk about not having haptics anymore, but we have, once you get used to this feel, it's just a different feel. So you have to really lightly tap, tap, tap that high-speed drill until you get your start point. I actually, because a lot of times we're going down these like really thin pedicles, I drill all the way down the pedicle, but I'm looking at the navigation screen and I'm making sure that I'm still feeling with my drill what I'm seeing on the screen so that I am comfortable with knowing that I'm not breaching. And again, one of the always things that we're worried about is our loss of accuracy. Especially because of these dysplastic pedicles. The platform is not going to know if you moved, and you really, 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 you must do your accuracy check before each screw when you're cannulating these like tiny, tiny, tiny little thoracic pedicles. So we just do that with a chicken foot. We place it on the spinous process. It takes an extra 2 seconds to do that in between each screw, and it's really helpful. This is an example of actually trying to figure out if you're actually off or if you just need to re-register your navigation. So this happened to me where the navigation actually was just off. I re-gingerbread man this instance, and it actually was more accurate. So once you feel like you're off, you again still have to go through those steps to check where exactly you're off, and if it's really is truly the navigation, truly the robotic robot that's off, or if it's just the navigation. One of the other things that we run into in peds a lot is the soft tissue impingement on the sleeve. When you're doing this MIS, we talked about you get that really big skin dissection, but then you're still going through the muscle. We still are doing it open. Maybe in the future, as we get better with our techniques, maybe we also will start to do a little bit of that. But right now, we're still dissecting the muscle away. And at the top, especially the top and the bottom, you really can get a pretty bad soft tissue impingement if you didn't do a good dissection carefully and have your retractors appropriately placed. So you can see here, example, that soft tissue obviously is going to change the trajectory of that cannula. So you need to make sure you're doing your dissection wide enough. If you're running into situations like this, we also will just do it transmuscular. I'll just put that muscle back where it was supposed to be and just do it, just through the fascia, or even percutaneous, like here when we do high-grade spondies is an example of that. We just do an entirely different incision actually and perk those screws. This also has been said already today, but you really, really must pick easy ones for your first cases, especially with bigger curves. That's just kind of a recipe for disaster to try those curves as your first cases. You must master the easy before you do the hard. This was my first case, super easy case, right? I don't need to do a robot for this case, but it just goes to show like these are the ones you have to do over and over and over to get really good at the robot before you can do the hard cases. One of the things that I think is different in peds is we do use a lot of uni screws, and so when you're doing this freehand or navigated, it's a little bit easier just to like have them line up because you're doing one sequentially after the other. When you are planning a robot plan, it's harder to see that. So how I do it right now, I will plan the screws, and then I'll actually go back through each level and make sure it's not more than 1 or 2 degrees off from the AP plane from each other, because then it just becomes too challenging to get your rod reduced. So that's one of the things. The Mazor software, I know we already saw this video earlier today, but the new software will make it a little bit easier to tell when you drop your rod which screws aren't going to be lined up enough. So that I think is going to make it a little bit easier to make sure screws are lined up okay for these bigger constructs. And that just goes to show, as these platforms get better, it's going to be easier for us to do these bigger surgeries and more facile at it and just more efficient. So really quickly, this was a case that I did that I think highlights how these screws can be so much better than just freehand or navigated screws. This is a 12-year-old girl. She was never braced. She came to me like this. She had 51-degree right thoracic, 56-degree left lumbar curve. I was able to do a CT to fluoro on her, which helped our efficiency. So these are her bending x-rays, our supine x-rays, structural curve. So my plan is to do T3 to L3 with some thoracic posterior column osteotomies. Like I said, I did it to CT to fluoro workflow. I did it with 2 registrations, actually. I did every single screw robotically in this case. I do use patient-specific rods on all of my AIS cases, and actually at this point, most of my neuromuscular cases. It's really nice for those cases as well. I use 6.0 cobalt chrome, and I get them differentially contoured. So on my convex side, I do -5 degrees of kyphosis, and my concave side, plus 10. And so my left rod in this situation was 40 degrees, and my right rod was 25 degrees of kyphosis built into that. So actually, when I placed my screws and dropped my rods, I dropped both rods at the same time, and then I used my reducers to pull the spine to the rods. And basically, with my differential contouring, it just derotates thoracic for you, which is really nice. I segmentally derotated the lumbar levels only, and I did a little bit of distraction at L3 just to get the L3 level. So basically, I did really minimal work after my screws were placed for this. I really didn't fidget with it that much, and this is what I got. And so I think this case, I really do believe that the robotic screws that we're putting in are just they're the optimal screws, and this is all very anecdotal. I don't have any evidence and data to support this yet, but I think these screws for pediatric deformity are so much more powerful, and we're going to be able to get so much better correction with them, especially when we're utilizing it with patient-specific rods. It basically makes our workflow optimized, and it makes everything more reproducible. I think peds deformity still is a little bit of more of an art and not so standardized as maybe adult deformity is. And this is moving towards standardizing it all. So future aspirations for me. Now we're talking about doing radiation-free robotic spine surgery with synthetic CTs that are now commercially available recently. I think this is really what's going to move the needle in pediatric spine for robotics. Once we can actually do these surgeries with very little radiation, basically only 2 C-arm shots, if I could do an entire construct with 2 C-arm shots, that's pretty incredible. And I think that's what's really going to get the pediatric surgeons to adopt this a little faster. So in summary, robotic-assisted spine surgery certainly does have a role in pediatrics. I think as these platforms evolve and we have more pediatric input into how the platforms evolve, it's going to become even more adopted. There is a little bit of a high learning curve because of the special nuances with the peds anatomy. So you really want to make sure you're thinking about those pitfalls that we went over. It is, at this point we have proved it's safe and accurate, and so some of the peds deformity surgeons just kind of need to get over that aspect and saying it's not, because it is. Radiation-free scoliosis surgery is probably here sooner rather than later, and I'm really excited about that. So thanks to Dr. Dan Hedequist, he gave me a lot of the pictures and videos for this talk. Here's my contact.
Real quickly, Kirsten, how are you managing blood loss for these patients?
Yeah, great question. I use Aquamanus, and so when I trained with Dr. Hedequist, he is like a stickler about if there's a cell of blood, you better be Aquamanusing that. Right. So I use Aquamanus very religiously, we still, kids are. kids bounce back a lot easier than adults. And so blood loss, like you have to be cognizant of it, and especially on the little kids, but it's not as big of a deal for their recovery. We also use Cell Saver in every case, and we're always giving them Cell Saver back. So our, I very rarely have to transfuse anybody. But Aquamanus, I think, is the key to that. Yeah.
Kirsten, I just want to say how impressed I am at how you have adopted all the new technologies. I know a lot of pediatric folks, Dave Skaggs included, and you are so farther ahead in all these enabling technologies than they are, and it's kind of crazy, interesting, exciting. I have kids, so to know that, this is slowly being embraced by the younger generation, I think this is really like take it and run with it, because you're going to be one of the few, I think, in the country that really master this and can speak to a different level. That's kind of the way Pat was when he did his, when he was using Nav and stuff like that. So just keep going.
Thank you.
My biggest question to you is, you harp on accuracy, so important, accuracy. But the last part where you want it to be accurate, you're putting it in freehand. Like, explain that dichotomy. With freehand. Like, I understand the issue because it's hard. You're torquing the spine. And you don't know if it, but like to me, I feel like that's missing the point.
Yeah, no, that's a good point. And so I think I said this earlier. I did not use any technology when I learned how to put pedicle screws in. So like for me, like the tactile feel of putting in a screw once you have your hole, like that makes more sense to me of actually knowing where I'm putting that screw. So when the way I do it, when you drill and tap, I do pretty much tap to the end of that. And one thing I actually didn't mention is I use the ball tip probe, and I feel like every step of the way to make sure that I don't have a medial breach. If I do feel like I have a medial breach after I've drilled or after I've tapped, I either will redirect it, or sometimes I will just skip that screw because we don't always need a 2.0 density construct, or I'll use hooks. If it's at the top, I'll use hooks. But I am feeling with the ball tip every step of the way to make sure that I'm not medial. And then to put the screws in, yes, we can put it in through the robot. I actually feel like, especially with those in-out-in screws, I think with the robot, it would be easier to skive lateral, actually, and misplace that screw rather than me putting it in freehand and having that tactile feedback of like, I know this is going in the right spot. That's also just in my hands because that's how I'm used to putting in difficult screws is with like, I don't use power. I've never really used power, and I feel like I lose the haptics of it when I'm using power. And so for those in-out-in screws, when you're, it's really easy if you don't get it in that exact spot, that screw will hit the body and then just skive lateral. And so I find it easier to actually put it in freehand when I know my trajectory with my ball tip probe. I can see that. I'll pull it out and just stick the screw in. Also, over a guide wire is not a terrible idea too. We will do that sometimes.
Yeah. I've lived this adventure before, and one of the mistakes that I learned the hard way was with the sharp tip screws.
Yeah.
So using a blunted tip screw, if you're already tapping, you already drilled the hole.
Yeah.
Your screw's going to go where your hole is, where you tapped it.
Yeah.
Unless it's sharp and it's going to cut through where you did. So I've when I'm doing the kind of thing you're doing. The other thing I really liked, and I think it's an important point to drive home for the other attendees, is when you're planning out your screws in those pre-planned manners, you're measuring the angles. If you put your screws at both levels at the same similar type angles, you said 2 to 3 degrees apart from itself, when you lay down your rod, once you've done your fascectomies, the bones will come to the center, right? It does it on its own. So you don't need a pre-contoured rod unless you want to use that for your own ease or convenience. Like, literally, it will do it. It will come there. Yeah. And so I think that's a really critical point, and I'm glad that you made it and just wanted to reemphasize it for the attendees.
Thank you.
Thank you.
Kirsten, thank you very much.
Thank you.
Excellent talk.
How do we get out of this?
We're going to keep moving, but I'm going to make one comment.
Yes.
Someday somebody's going to give a lecture about costotransverse screws and if, when, and how robotics is appropriate there. Because I put them in a lot of people, and in fact, I just had a patient the other day that had a fracture in the thoracic spine, and I put in those kind of screws, and I couldn't do it with the robot, even with all of our caveats that we have learned here this morning about precision and to do it to perfection. Cost of transfer screws, which some people, that's all you can put into them. That's it. And pediatrics is a place where that happens. So anyway, I'm going to listen to myself and shut up and move on. We're going to get back to our